Hello everyone, welcome to Noble Psychiatric Services presentation. I'm Dr. Ondieki, one of the guys behind Noble Psychiatry and Noble Pathway, and I'm excited to welcome you to this presentation. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we encounter individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions that affect not only their mental health, but their families, relationships, and the quality of life. That is why this conversation is important. Today, we'll explore schizophrenia in a practical, evidence-based, and clinically relevant way aimed at improving patient care and strengthening our approach as mental health professionals. Thank you for being here, and we will get started. This presentation has been designed and produced by the Noble Psychiatric Services. The presentation presents psychotic disorders and schizophrenia spectrum disease from a clinical and neurobiological perspective. The DSM-5 framework, which emphasizes the existence of delusion, hallucination, and disordered thinking and negative symptoms that last at least 6 months, will be examined by the trainees in order to diagnose schizophrenia and related disorders. The session will examine neurobiological causes of psychosis such as glutamatergic circuits and anomalies and dopaminergic dysregulation, and how these mechanisms show up both positive and negative symptoms. In addition of understanding the role of the genetic susceptibility and environmental stressors in the genesis of the condition, trainees will learn to distinguish schizophrenia with mood-related and substance-induced psychosis. Subsequently, the talk will go over evidence-based management approaches, emphasizing psychosocial therapies like CBT for psychosis, family psychoeducation, and recovery-oriented care, as well as pharmacological intervention such as antipsychotics or long-term injectables. When you look at the epidemiology and impact, about 1% of the worldwide suffer with schizophrenia, which is more common across the wider spectrum of psychosis and varies significantly by gender and geography. Usually occurring in late adolescence to early adulthood, earlier in males, the onset marks a crucial developmental window that frequently interferes with the social functioning, work, and education. Due to the concomitant medical conditions and the increased risk of suicide, these disorders are a major global cause of disability, significantly increasing years lived with disability and premature mortality. Affecting persons have 10 to 20 years shorter life expectancy. Recognizing these epidemiological patterns highlight the critical need for early detection, ongoing treatment participation, as well as all-encompassing community-based treatment that targets systematic health inequalities as well as psychiatric symptoms. As far as the schizophrenia spectrum is described in this slide as a variety of related diseases from persistent psychotic illness to personality level features. According to the DSM-5, it views psychosis as a spectrum that includes schizotypal personality disorders, brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, and psychotic disorders brought on by drugs or illnesses. According to the American Association of American Psychiatric Association, the differing degrees of the symptoms, duration, and the functional impairment, this dimensional model represents common pathopsychological pathways and genetic vulnerabilities among the illness. Clinicians can better understand the progressive nature of the psychotic illness from temporary or stress-induced psychosis to persistent treatment-refractory schizophrenia by visualizing the spectrum as a continuum. To enable timely management and avoid long-term incapacity, trainees are urged to understand early or attenuate symptoms within a range. The section focuses on the primary symptoms dimension that characterize schizophrenia and kindred psychotic diseases. Clinically, symptoms are divided into 4 areas. We have the positive, negative, cognitive, and mood-related. Each of the domains have a distinctive impact on the treatment responses and functional impairment. Antipsychotic drugs usually work for positive symptoms such as hallucinations and delusions and disordered speech or behavior, which are excesses or distortions of the normal function. Negative symptoms, on the other hand, are more resistant to pharmacological treatment and indicate a loss or decrease of the normal emotional or motivational processing. These symptoms include flat affect, alogia, avolition, or anhedonia. Deficits in executive function, working memory, and attention are examples of cognitive symptoms that are highly predictive of recovery potential and real-world functioning. Mood problems such as anxiety or sadness sometimes coincide and make diagnosis and treatment more difficult. Clinicians can create complete treatment regimen that include social and cognitive rehabilitation in addition to psychosis reduction by having a thorough understanding of the multifaceted symptoms structure. As far as the neurobiology and the pathophysiology, in this presentation, it integrates the research from neurochemistry, neuroanatomy, and the developmental science to examine the neurological undermining of psychotic illnesses and schizophrenia. The dopamine hypothesis, which contains that hypofunction in the mesocortical pathway results in the negative and the cognitive deficiencies, while hyperactivities in the mesolimbic pathway contribute to the positive symptoms like hallucinations and delusional, is a key theory. Beyond dopamine, cortical dysfunction and compromised synaptic plasticity have been linked to glutamatergic dysregulation, especially or specifically decreased NMDA receptors activation. The idea of extensive brain network distributed is supported by structural neuroimaging, which regularly shows larger ventricles, decreased cortical and hippocampal sizes, and as also the prefrontal temporal connections that are tempered. The neurodevelopmental hypothesis, which suggests that the genetic susceptibility combines with environmental factors such as prenatal infection, postnatal issues, cannabis exposure, and psychosocial stressors to altered brain maturation and stress responses circuits, summarizes these findings. When trainees are aware that these scientific processes, they are better able to contextualize psychosis as a brain-based disorder rather than just behavioral manifestation, which promotes empathy as well as prescribes treatment planning. As far as the differential, there is a few differential when you think about schizophrenia. We have psychosis, we have bipolar, we also have those that are brought by substances as far as stimulants as well as cannabis. We also have medical conditions including autoimmune, dementia, delirium, as well as temporal lobe epilepsy. When we think about the pharmacological aspect, pharmacological intervention is the cornerstone of treatment for schizophrenia and primarily involves the use of antipsychotic medications. These medications are effective in managing symptoms in modulating neurotransmitter activities, particularly through the dopamine D2 receptors antagonism, which reduces positive symptoms such as hallucinations or delusions. Antipsychotic medications are classified into the first generation FGAs and second generation antipsychotic as SGAs. First generation antipsychotics include haloperidol and are effective in controlling positive symptoms. However, their use is limited by the higher incidence of extrapyramidal side effects such as dystonia, Parkinsonism, as well as tardive dyskinesia. On the other hand, second generation antipsychotics such as risperdal, olanzapine, or quetiapine, or aripiprazole are generally preferred as the first line due to their reduced risk of extrapyramidal symptoms and greater efficacy in addressing negative symptoms and cognitive deficits. Despite these advantages, SGAs are associated with a metabolic adverse effect, including weight gain, insulin resistance, and dyslipidemia, necessitating ongoing metabolic monitoring. Clozapine is indicated for treatment-resistant schizophrenia and has demonstrated superior efficacy in patients who do not respond to the other antipsychotic. Its use requires regular hematological monitoring due to the risk of agranulocytosis. Additional long-acting injectable antipsychotics may be used to enhance medication adherence and reduce relapse rates. Optimal management of schizophrenia integrates pharmacological therapies with psychosocial intervention to improve functional outcomes as well as the quality of life. Some of the non-pharmacological treatments, the importance of the psychosocial and non-pharmacological therapies in all-encompassing treatment of schizophrenia is the main topic on this section. Psychosocial therapies address the cognitive, emotional, and social aspects of the recovery, while medication continues to be the cornerstone of the treatment. Patients with psychosis can lessen the emotional effect of delusional and hallucination by using cognitive behavioral therapy to reframe upsetting beliefs and enhancing coping mechanisms. By assisting families with comprehending the condition and actively engaging in care, families' psychoeducation is another evidence-based strategy that enhances communication, lowers relapse rates, as well as fortifies support network. Through social skills training and support job programs and enhanced community functions that promotes independence, patients may regain a sense of stability and purpose. Assertive community treatment, ACT, provides interpersonal, interdisciplinary, intensive outreach for people with severe illness who struggle to follow treatment regimen or have insecure housing. Finally, by focusing on optimism, empowerment, and stigma reduction, recovery-oriented care motivates patients to pursue important life goals beyond symptoms control. Combining these psychosocial strategies with medication therapy yields the best long-term outcome. As far as the side effects, one adverse effect of antipsychotic can be significantly interfere with the day-to-day activities. For example, tardive dyskinesia. Fine motor skills are hampered as a result of erratic involuntary movement. Sedation and dizziness are the two most serious side effects that occur that make people feel weary all the time. This makes it challenging to maintain proper hygiene, attend appointments, and complete tasks on time. Additional dizziness is another harmful side effect that causes nausea, stumbling, as well as balance issue. Gynecomastia can also result from Risperdal, a second-generational antipsychotic that raises the prolactin levels in men. Men with enlarged breast may have lower self-esteem, feeling of inadequacy, and definitely decreased or declined level of confidence. And that concludes the presentation on schizophrenia. If you have any questions or have any concerns, or you feel free to send us an email or leave a comment, and we will be glad to answer your question. With that, from Noble Psychiatric Services, we wish you nothing but the best.